Everybody on Zoom. Hey guys, just trying to get everything up and running for you guys today. I hope you all are doing well. So excited to have y'all today. And if we haven't met, my name is Brittany, and I'm a nurse practitioner here at Archer Review. And today we're going to be going through some really exciting things pertinent to men's health. So let's go ahead. And if you are just now joining us, you can go ahead and join in on our Slido. So I have a Slido up here for y'all. And I want to know what you guys are studying this week. So let's go ahead and pull that up for you. And let me pull this over. Okay, there you go. So you guys can join in at Slido. If you're just now joining in, even if you are on Instagram or Facebook, you can go to slido.com, hashtag Archer, AR male, and you will see our Slido. So you guys go ahead and pull that up. And I am so excited to get to present to y'all today, as always. And we are working on remediation so far, is what I'm hearing. So let me know what else you guys are studying this week. That way, hopefully, you got some men's health topics in there. But even if you don't, this will be a good review for you. So go ahead, join at Slido.com, hashtag capital A, capital R, male. So I see a few of you guys have already chimed in comprehensive review this week. So somebody's getting ready to take boards. Rheumatology, oh, that's another one that we definitely want to be studying up on. So you guys, I know, are out there working really hard today. So again, good luck with everything that you're studying this week. And yes, if the chat's disabled, you can put it in Q&A. That's okay. Or you can come over here to Slido and put it in here. GYN conditions. Okay, I'm seeing that. So here's the other thing I'm going to tell you guys. If the chat is acting up, and I'm going to try to come in here and work on that for you. But if it's acting up, you can put it in Q&A and tell me. Now, remember, if you're replying on Zoom, then I'm going to see who it's from. And that's okay. I'm happy to talk to you and connect there. But if you want to be a little bit more anonymous, a little more incognito, then you're going to come onto slido.com and you're going to join our code at hashtag capital A, capital R, like in Archer Review, and then lowercase male. So again, give you just a minute to log on to Slido because I don't like talking to myself. So it's fun when we can all be together. And I see a few other people joining in. Welcome. Cardiac is coming up, debating on a date for your exam. Absolutely. That takes time and energy just to even look at the exams and figure out which one you want to take. So I get you. So anyways, if you're just now joining again, my name's Brittany. I'm a nurse practitioner here at Archer, and I'm so happy to have all of you guys here today. I will go ahead and put up the Slido QR code for you. If you want to go ahead and pop in here, I have it up there for you and you can join our poll. So let's go ahead. I'm going to scroll back here just a little bit. I have some really exciting news for you guys. We just in the last month have started offering continuing education, and that way we can give you all a contact hour for your time. And especially if you're doing like that remediation or whatever, or you're trying to renew your license, maybe you're already an NP, and you can get that hour of your time. Now, you have to do it via Zoom, and you have to be here at least 80% of the time. So let me pull that up for you all. And you have to join via Zoom so that we have your email address so that we know where to send your certificate to. Now, if you didn't join via Zoom today, maybe you're on Facebook or Instagram, that's okay. There's going to be more webinars just like this coming up this next week. In fact, I'm again with you next Monday. So you all have time to go back to our website and sign up for that. Also, no relevant financial relationships or any commercial interest for this educational activity. This is just us offering this to you guys as a service. And then, of course, we have our learning objectives. We're going to identify concerns a patient with male anatomy may want to discuss with a primary care provider. So I want you to think about BPH, I want you to think about ED, all these different things that your patient with male anatomy might come in and want to talk to you about. In addition, we're going to explain assessment techniques to evaluate the male reproductive and urinary system, which is all kind of right there together. And we're also going to demonstrate an understanding of diagnostic criteria and treatment options for conditions affecting those with male anatomy. So again, I want y'all to be able to do these objectives by the end of our webinar today. And of course, we are credentialed through the American Continuing Professional Development through ANCC. So that's really exciting. Again, if you are just joining us, that's new this month. And also, if you are just joining, here's that Slido QR code. So join in there. And if you haven't done so, again, hashtag capital A, capital R, male at slido.com if you're joining via Instagram. So again, just happy to have all of y'all here. All right, so let's go ahead and dig into our topic today. We have so much to cover and so much to look through. And this is just a male anatomy here. You can take a look, you can reorient yourself here. And one thing really here is that the male reproductive and urinary structures system pretty much share the same structures. Think about like the urethra, it can carry both urine and sperm. So just think about that as we're going through here, as you are reorienting yourself, and just take a look and kind of refamiliarize yourself with where everything's at. Maybe it's been a minute since you've looked at this picture, and I want you all to be good and clear of exactly what we're talking about when we get into the structure and function of everything. Okay. So let's go ahead and just review the prostate's structure and function and how to assess it. So I've got this information up here for y'all. This is on the prostate. It's a walnut-shaped gland situated below the bladder and in front of the rectum. And this is kind of subdivided into like 5 lobes, and 3 zones. So I have a picture up here for you guys, and here's showing the anterior view of the prostate in its normal location, looking at it from the front, kind of the prostate. And you can see here that urethra goes right through that structure, and you can see that the urine kind of passes through the urethra there. So when we're going through things like benign prostatic hyperplasia and other things, I want you to think about where this is located, and that's going to help give you a little bit clearer picture as we're talking about some of the pathophysiology as we go along. Again, 3 zones, and I have some pictures for you here. BPH mainly focuses on this transitional zone, which is up here by the urethra. And I have another picture for y'all here coming up here in a minute, so don't worry too much about that. Also, we are going to be performing a digital rectal exam to assess the prostate. That is what the healthcare provider is going to do. And essentially, we're going to be feeling that posterior surface of the prostate. So we're not going to be able to feel all 5 lobes, but we will be able to usually feel 2. And a lot of times prostate cancer kind of likes to hide out in this area. So if a digital rectal exam is warranted for your patient, just know that that's kind of what you're feeling when you reach through and feel the prostate via the rectum. Normal size of a prostate is about 2 to 3 centimeters across, and a slightly enlarged prostate will be sometimes described as like +1 or +2. And if you chart +2, then that's going to basically mean that the prostate is double the size of a normal prostate, or about 4 finger breadths when you measure it across. Occasionally you'll see a +3 or +4, but that would be a really enlarged prostate. You're probably working in urology at this point, and it may even be pressing against the structures on the rectal wall. So again, that's a really enlarged prostate there. But the main job of the prostate is to produce and fortify seminal fluid and help transport the sperm through the urethra. And again, we talked about the assessment here. Let's just talk about some of these normal possible findings here. So how you might describe the prostate or see it described is it's smooth, it is firm, it is non-tender. You can palpate two distinct lateral lobes. This is going to be again done with that digital rectal exam by the healthcare provider inserting a gloved and lubricated finger gently into the rectum and kind of assessing the size, shape, and texture of the prostate. Also, the other thing that you might see if it's an abnormal prostate exam is words to describe that might be like hard or lumpy or asymmetrical. Think about you should be feeling those two distinct lobes when you're feeling posteriorly. A palpable node, enlarged and boggy or tender, and that one should kind of tip you off to something like maybe like an infection like prostatitis. Again, that is kind of the structure and function of the prostate and kind of how to perform a digital rectal exam. All right, let's go ahead and do our first practice question. I'm going to pull the Slido up for you guys here just in a second, but I want to know all of the following are common symptoms of benign prostatic hyperplasia in men less than 60 years old, except, and let's go ahead and go to that question here. Well, maybe. Let's see here. I don't know why it's not letting me change. You guys put a lot of stuff that y'all are studying this week. I love it. That's great. Let's see here. Usually it lets me change over. Here we go. Okay, so I tell you what, before we get to this practice question, I wanted to ask you guys what your background and training is. So let's go ahead and fill that out. I got ahead of myself, didn't I? Let me know kind of what you're doing right now. So I know some of you guys are probably prepping for nurse practitioner boards. Some of you might be practicing for your NCLEX or maybe a different advanced practice nurse. Some of you guys might be looking at going to school for advanced practice. Some of you guys might already be licensed as advanced practice nurses. So just let me know who I'm kind of out there talking to today. Great, FNP, NP student, that's right. So you guys don't forget to get your contact hours today if you haven't done so already. So, okay, great. Practicing for your board retake. Okay. All right, great. So you guys are doing lots of different things. Well-educated group here. Great. Director. Wonderful. I love that. So we have lots of people here today, and I love just getting to kind of hear a little bit about your background and your story. Okay, so how do you all feel about your knowledge on men's health topics? So again, I'm getting ready to get to this practice question here just in a second. How are y'all feeling? Okay, y'all are already feeling good about it? Good. Okay, few feeling a little bit nervous. Okay, a little bit in between, and that's okay. Here's the thing is you can always come back around and study and look through this again, and that's okay. That's what we're here for. So I'm glad that you guys are already feeling kind of good about some of these topics today. And if you're not, that's okay too. We're going to refresh together. All right, so here's that practice question for y'all. All of the following are common symptoms of benign prostatic hyperplasia in men less than 60 years old, except, right? And if you're taking a boards test or a practice question, you want to pay attention to your language, except, right? So thinking that three of these are going to be pretty common symptoms. And one of them is going to be not very common or not really seen. So think about paying attention to your language when you're answering these questions. Okay. So always read every word. Okay. So, all right, great job, you guys. That's right. The answer to this is hematuria. You guys are right. And this one here, men over the age of 60 are more likely to experience hematuria with BPH. But again, hematuria is usually not normal. And so we would want to do a little bit more of a workup, right? So again, this is something it's more common over the age of 60, but needs probably a little bit further investigation. All right, so let's take a look here. And let's talk about this benign prostate hyperplasia. This is a very common condition. It is BPH for short. And a lot of times the cause is idiopathic, meaning we don't really know why the patient's having this. However, aging is a primary risk factor. Some of the studies that I've read, most of these men, by the time they're age 50 years old, have some sort of prostate enlargement. And, as they increase to 80 years old, it's just going to increase. 80 to 90% of these people are going to have prostate enlargement by the age of 80. And again, we don't know all the reasons, but one of the things is hormonal changes with the development of BPH. And if you guys remember, testosterone is converted to dihydrotestosterone or DHT by 5-alpha reductase. And this then kind of leads to that glandular enlargement. And then if you remember, that is going to compress the urethra as that prostate grows and swells and that tissue gets bigger and bigger. And it's going to compress the urethra and lead to something called bladder outlet obstruction. Basically, that's anything that's going to block the neck of that bladder there. And so essentially thinking about an enlarged prostate, a bladder stone, even a tumor, anything can cause that, but we're really focusing on the cause of it being BPH right now today. And of course, those lower urinary symptoms are going to be really common with BPH. So think about things like urinary frequency, urgency, weak urine stream, hesitation, feelings of urinary retention, or actual urinary retention, all can kind of go together with this BPH. And one of the things that we're going to want to do if our patient kind of comes in complaining of some of these things is we're going to try to do a little bit more of a workup. So let's say that this is a little bit older person, and maybe they have some obesity or even metabolic syndrome or genetic predisposition, whatever they may be having going on with them. They're complaining of some of these symptoms. And we are going to talk about getting a PSA on them, prostate specific antigen. If y'all remember, that's that lab that's kind of checking and screening for prostate cancer. And we're going to talk a little bit more about that here just in a few minutes about that lab. Also, a urinalysis with culture, especially if they're coming in with these, lower urinary tract symptoms. We need to rule that out, a UTI. So things like urgency, especially if they have hematuria, frequency, all of those things. We are also going to look at their comprehensive metabolic panel. We don't want to be missing anything, like if their urine stream is so blocked off, they could be having something going on with their kidneys, and we want to make sure that that their kidney function is good. And then, of course, we may choose to also do that digital rectal exam, and the prostate might be described as firm, smooth, and enlarged, and we can't really differentiate between the two lobes super well. Here's your clinical pearl right here for you guys. PSA greater than 4 will require a further workup with urology most of the time. So again, this is something that you're going to want to pay attention to, kind of commit to memory if you do decide to get that PSA with your patient. Anything over 4 will be a urology referral. So again, we're going to talk a little bit more about PSA in the webinar, so don't fret too much. All right, so let's talk about treatments. There's not a lot of things that we often will start with unless they're having a whole lot of symptoms. So sometimes we just monitor symptoms. Sometimes we recommend lifestyle changes. So thinking about things like, urinary urgency and frequency. We might have them to kind of, or nocturia, we might have them to kind of cut their water down at night. Or maybe they're on some sort of anticholinergic med or decongestant medication. We're going to have them to kind of cut that out. Maybe we have them to cut down on caffeine because that's a bladder irritant. So just some like lifestyle changes we can do. And then our first line treatment based upon their symptoms is going to be medication-wise is going to be our alpha-1 blocker. So I want you to think about like tamsulosin or Flomax or those 5-alpha reductase inhibitors that we just talked about, how that kind of goes towards the prostate and its enlargement. We're going to think about inhibiting that. And so finasteride or Proscar, as y'all might know it as. And then more severe cases will probably prompt a urology referral. They have lots and lots of minimally invasive surgeries. There's a few of them out there right now. There's like one called transurethral microwave thermotherapy, which kind of uses those waves to destroy the prostate tissue. And then another one is a transurethral resection of the prostate, also known as a TURP. And this one's really reserved for more severe cases because they're actually going to remove tissue from the prostate. And you can see here on my picture, so we have the normal prostate where the urine can flow down really well. We have that BPH here. And this one here is going to be, there's that zone of transition zone that really kind of swells and causes the symptoms of BPH. And you can see here, there's a little bit better picture of it kind of blown up and from the side. And that is going to be the area that these surgeries are kind of focusing on to really target so that they can open that urethra back up and get the urine flowing a little bit better and relieve some of the symptoms. All right. So let's talk about alpha-1 blockers. Some of the really common ones that we'll use for BPH is tamsulosin or Flomax, alfluzocin, and then there's another one called Cardura on the market. And you can see here, these right here, again, are going to be BPH, but then also like you see Cardura here. Sometimes there's some uses for these with hypertension. And then also we can use Flomax especially, but we can use these off-label for anything that causes a urinary obstruction. So again, we think about like things like bladder stones or things. And so anything that we want to kind of utilize to relax that smooth muscle, because that's how these work, promote vasodilation, block that norepinephrine, and basically help them to urinate. So that's how this is going to work. And again, it's got those off-label uses for that. Some of the prescribing considerations I want you to think about is the hypotension, orthostatic hypotension. So we're going to really educate our patients to take these first dose at night. They're going to have positional change slowly because they might be dizzy. They might need to dangle their legs when they're sitting up, going from laying down to sitting up. They also might have things like nasal congestion. If these patients are experiencing things like liver disease or heart failure, this is not going to be really a good thing for them, thinking about how it works to relax the smooth muscles. And then also cataract surgery, the same kind of thing. Think about our eyes. You can get something called floppy iris syndrome, I think is what it's called. And again, just with how it works. So if they have some of these other things going on, if their blood pressure is naturally low or they're on a lot of medication and we're trying to really titrate to keep their blood pressure really low, this is probably not the best drug class for these patients. All right. The next kind of category that we're going to look to help with symptoms of BPH is alpha reductase inhibitors. These also have an off-label use for male pattern baldness and urinary retention. Well, should I say it this way? Finasteride is on label for male pattern baldness, but some of these other ones are not. But these pretty much work to block the action of the enzyme 5-alpha reductase. So we talked about how that contributes to that enlargement of that prostate gland earlier. And essentially, we're trying to have them to keep their testosterone levels at a steady state and not go and have too much of the DHT or the dihydrotestosterone. So just like we talked about with the structure and function and the pathophysiology of BPH. Some of the prescribing considerations that I want you to think about here, and I have a picture for you, again, just of kind of how this is going to work is, erectile dysfunction, low libido, depression. There is a suicide ideation risk for younger people on this medication. One of the things that this one is also a category X for pregnancy. So these patients, it is teratogenic. It is not good for little bitty babies in utero. And if the patient is pregnant or they're a female of childbearing age or they are a child, then they don't even need to touch this medication because, again, with how this works. And then also just remind your patient it's probably going to take about 3 to 6 months to really get this working because it's actually shrinking the tissue. So we're going to get a baseline PSA. We want to do prostate cancer screenings routinely because there is a little bit of a risk with this. And then also I put on here to avoid touching if you could be pregnant. So again, that is that drug class for you guys, just a little bit of review. All right, so let's go ahead and take a look here. Just have a little brain break. So that was a lot about BPH, and that was a lot about how those medications work. So let's just have a breath, and I have another slide I pulled for you guys. I want to ask you guys, which are your products you'd like to hear more about today? So usually I give y'all this little slide here, and I talk about all the things, and some of y'all might just be joining us today, and we'll go through them. But we're here to kind of help and support you. Some of you guys are going to be doing remediation for tests, or you have your upcoming boards, and we just want to know how we can reach out to you through this computer screen, connect, and be able to really be a support for you. So we have lots of different things, lots of different products, and I want to know which one you guys are the most interested in today. Absolutely. So let's talk a little bit about these. So tutoring, mentoring. So basically, you and I, or whoever is on that day, whoever you pick around your schedule, and if there's a time that doesn't work for you, you can reach out, and we will try to make a time for you. We've done that before. We have an email address. In fact, here's our email address to reach out right here: nursepractitioner@archerreview.com. But we will sit down together and we will work through what you want to work through. We can get together a study plan, a roadmap for your success, and you can get tutoring and mentoring packages by the hour, a la carte. If you get our SurePass package, which somebody's already wanting to hear a little bit more about that, and that's really exciting. I love that because it actually has a couple mentoring sessions thrown in. So whether you're just starting as an NP or maybe you're a student NP, it's really going to be good for you to have that mentor or tutor of somebody who's actually been there and can kind of help walk you through your questions. The other thing is that if you get the SurePass Pro package, you're going to get the question bank. So over here, always has a free trial of over 1,600 questions with rationales. Sometimes there's videos connected to that, especially if you get the on-demand package with it. And it also includes the on-demand. So maybe you want to hear a lecture just on BPH. You can go and you can pull that up on demand. You can do some questions on it and really make sure that you're feeling solid on that content. And then also, we have a live review, and that's another thing that's going to be coming up in May. Really exciting time where we spend 2 or 3 days just really going together and working through, practice questions and really hitting the high levels, high yield for boards. So if you're getting ready to take your boards, that might be something that you're, really interested in, looking at the SurePass Pro or some of these things a la carte. All right, let's see here. CE opportunities. Right now, we're in a CE opportunity. So that is really great because even if you missed it today, if you missed the beginning of our webinar today, what's really great is that you can have a continuing education hour, and you can get that by joining via Zoom. So we have lots of different ways that you can get these contact hours in. And then, of course, the 3-day review, we talked about that a little bit. That one is going to be coming up here at the end of May, and you can look on our website. I'm sure that the registration will be opening for that soon. That's a really great time where we can just kind of come together and work on things, just go through it system by system. And then how the QBank works. And that's a really great one as well. There's a free 7-day trial for everybody. So if you're getting ready to take your boards coming up in the next week or two and you want to review, there's no reason why you shouldn't be signed up for that question bank. And then also the nice thing about this one is that there's a readiness predictor for this. And it kind of helps to gauge like how you're doing, like versus where your peers are at and how you're doing up against them, and working together with over 1,600 questions. So pretty much the topics are unlimited there that you can pick out and choose to do. And of course, if you don't buy anything today, that's okay. We just want you to connect with us and If you're already watching on Facebook or YouTube or Instagram, welcome. We have lots of different things here. Sometimes we do giveaways on there. We just want you to join our community. You can scan this QR code and we'll be happy to connect with you in any way that we can. So if you have specific questions, let me know. You can utilize the Q Bank, or not the Q Bank, but the Q&A in Zoom, or you can put it in one of these open text box and I'll go back through and we can look at everything. All right, so let's go ahead and look a little bit more about some of these conditions here. I have a few little emergent urology things in this section here. So let's think about priapism. And this one is not for the faint of heart. This is essentially an erection that lasts over 4 hours. So, you know, when they're talking real fast on the commercials, go to the emergency room for any erection lasting over 4 hours. Well, that is the medical name for this right here. And this is a prolonged, painful erection, sticks around way longer. And of course, these medications can cause this. But one of the other things that causes this 50% of the time that a lot of people don't know is sickle cell disease. Think about how those sickle cells are going to be shaped, if you will, and about the tissue there. And you put all that together, and that is going to cause this issue. Again, very painful. Malignancies, alcohol or drug use, anything that's going to basically make the slowing of the blood and get the blood trapped in the penis. So this is going to be something that is going to be painful for these patients, and they may even have to do surgical intervention if after 15 hours. They might try to irrigate or aspirate for the first few, but then they may have to carry them to surgery. So again, this is a urgent, emergent condition that you're going to have the patient to go to the emergency room for. All right, let's look at this one here. Erectile dysfunction. So this is on the opposite end of the spectrum. This one is essentially trouble achieving or maintaining an erection. And I have listed all the risk factors for you guys on the slide. So you can see hypertension, heart health, mental health, liver or renal disease, and then of course obesity, diabetes. All these things can really lead to make the perfect storm and lead to erectile dysfunction. And the International Index of Erectile Function Questionnaire is really a great tool to use to help guide your treatment options. And it's just a tool. It's not a diagnosis. It just kind of helps give you a starting place to try to find the root cause. And we're going to get to practice a little bit with that here shortly. It asks questions like how long can erection last, or is the problem stable or getting worse? And patients oftentimes will find it a little bit easier to be open and honest on a paper versus me looking them in the eye and talking to them. And usually that'll just kind of make, kind of break the ice and tension, and then kind of get the conversation flowing in a little bit more natural way. And we also aren't going to skip out on any diagnostics if our patient complains of this. We're going to look at everything from their mental health to their vital signs, think about hypertension, and then blood tests to screen for things like diabetes, kidney disease, heart disease, and make sure that there aren't any underlying reasons that this erectile dysfunction is occurring. Also, I've put here a link. If you want to save this right here, this is that International Erectile Function Questionnaire. So if you want to take this link right here, you can, because we're going to look at that together. I've got it on a slide coming up, but if you want to see the whole thing, there it is. All right, so let's go ahead and do a practice question. Mr. Smith is 52 years old and is asking for tadalafil or Cialis today, and the following medications are listed on his record. Which medication requires further investigation before prescribing the refill? So I'm going to go ahead and pull up Slido for you. Here we go. And go ahead and tell me which one you all think is going to be the one that we need to investigate a little bit more, find out why he's taking that. Absolutely. Great job. So you guys got it. Nitroglycerin, absolutely. So let's talk about that. So say we've done all of our assessments, and we basically have thought about what we want to do. Things just kind of aren't adding up, and we're not really finding the reason why this ED is occurring. Sometimes there's no physiological cause, and it could be psychological. And in terms of treatment, where you're going to really want to talk things through and practice your shared decision making is see about the patients what they want to do. Maybe they want to start with lifestyle modifications. If their blood sugar's out of control, let's get that under control. Maybe they want to exercise more because we know that strength and weight training can sometimes increase testosterone. Sometimes they want to, go see urology and see what all their options are, and that's okay too. Some of these patients might go for psychotherapy, and before they just jump straight into medications. And again, there's no right or wrong way with where we want to start, but we're just going to really kind of help lay out the options for the patient and help them with their shared decision making. And then medications, of course, our number one class is going to be that PDE5 inhibitor. And right here, I have it listed for y'all, and you all got this question right already, so y'all know this. Taking nitrates for chest pain is a contraindication for PDE5 medication. So let's explore that. Let's talk a little bit more about why. So how these medications work, they're going to inhibit the breakdown of cyclic guanidine monophosphatase. And that is a really fancy word for this nucleotide that's a molecule and helps to relax smooth muscle and promote vasodilation. And what does nitroglycerin do? It also helps to promote vasodilation, right? And of course, these medications, things like Viagra, Cialis, those are your common ones here. They are indicated for things like BPH, the tadalafil specifically, ED, and then there's also pulmonary arterial hypertension. So you might even see a few female patients taking these on occasion. And some of the things that this can cause, thinking about vasodilation of all the vessels in the body, headache and flushing, dyspepsia. Of course, people with hypotension or heart disease, they probably aren't going to be a really great, candidate for this. If they have a history of that erection lasting more than 4 hours, probably not going to be a good candidate for these. And then, of course, don't take with nitrates. They need to monitor for signs and symptoms of orthostatic hypotension. So again, if they're going from laying to sitting to standing, move slowly. If their body is going to be operating, if they're going to be operating heavy machinery, they need to know how their body's going to react. And then, of course, ER for an erection lasting over 4 hours. And another education point that some of these patients don't always know is that they do have to have sexual stimulation for these to work for ED. So they're not just going to take it and boom, it's going to happen. And we need to really educate our patients so that they kind of know what to expect when they take these medications. All right, let's go ahead and look at this practice question together. An uncircumcised patient may develop balanitis. Which of the following is a related emergent condition? So I told you this little section has some little emergencies in there. So which one is a related to balanitis? It's an emergent condition. So paraphimosis, hydrocele, phimosis, or Peyronie's disease. So y'all go ahead and put in, I'll give y'all just a minute to think about that, what y'all are thinking for which one it is, and which one is going to be one that you all are going to end up sending to the emergency room. Okay, we're split 50-50. That's okay. All right, so I'll give you just a minute. Think about it. Which one is emergent? Which one is the one that we need to really pay attention to? You guys are fighting back and forth there. It's okay. I'll give you just a minute. Think about it. Which one is an emergency condition? All right. So let's take a look here. Paraphimosis. Okay. So that is going to be the answer to that one. So great job, guys. I know that's always a confusion. So let's clear that up. That's very common for students and even nurse practitioners to be like, I can't remember. I know it's one of those. So let's look at this. Okay. So First of all, ballantitis, just a fancy word to say infection of the glands or the head of the penis, the tip of the penis. A lot of times these are just going to be due to poor hygiene, obesity, and these patients will kind of develop like a fungal or yeast infection in the area. Soaps and detergents can also irritate the area as well, again, contributing to these little infections. Symptoms are going to be like thick white discharge or tight and red, angry looking foreskin in an uncircumcised patient, and then painful urination they might complain of. And then this one's pretty much going to be treated with some topicals. Think about your diflucan for your antifungals. And also, a recurrent cases of this can go to urology. We might want to think about, offering that patient a circumcision or something like that. Now, if the foreskin becomes too tight over the penis and is unable to be retracted, it becomes an emergent condition known as paraphimosis. So let's take a look at this picture right here. We have normal, can be retracted and moved into place to cover the glands, okay? Now we have phimosis, is narrow opening of the foreskin. It's really hard to pull this back. And then this is the one that's the emergency, the paraphimosis. What happens is that foreskin is retracted and the glands area kind of swells up and they cannot get that back over that swollen area and move the foreskin back into place. And again, this is the one that's the emergency. So look and see, these are pretty much opposite of each other. And here's normal, like I say, and just look at this and kind of get in your mind what is the problem. And you can see here, this is red, swollen, and painful, red emergency box. So that's kind of how I've connected this together for you guys. And it just is not going to go down. So good job with that. That was a tricky question. Sorry, I didn't mean to be tricky. All right, so just a few other little things here that I'm going to mention is Peyronie's disease. This is a painful condition where scar tissue kind of builds up and causes this penis to curve, bend, or reduce in size, essentially affecting males middle-aged, and this is going to be diagnosed via ultrasound. This can be acute or chronic, treated with medications, traction therapy, or surgery. And these patients will probably end up going to urology. And I actually didn't have a picture for y'all. So that's something that you'll just look up in your book. All right, let's look at this practice question. Jason, an 8-month-old male, is here today for his checkup. His mother states the pediatrician has been monitoring an undescended testicle on the right side of his scrotum, and she notes that she's unable to feel anything coming down and would like for the nurse practitioner to check today. The nurse practitioner is also unable to palpate the right testicle and orders an ultrasound. The ultrasound confirms that the testicle remains in his abdominal cavity. What is going to be the next step? So let's go ahead and pull up Slido. Okay, you haven't joined in on the fun. Hashtag capital A, capital R, male. There's still some polls to do. Let's go ahead and vote as a group what we're going to do. So are we going to reassure his mother that the testicle will come down? We'll make a 3-month follow-up to repeat the ultrasound. We'll tell Jason's mother to apply a warm, moist compress to the area, or we're going to refer Jason to pediatric urology. So Jason's 8 months old. He has an undescended testicle. And what are we going to do for Jason today? So the ultrasound has confirmed that it's still kind of up there in the abdominal cavity. So what are we going to choose? What are we going to do? And we're going to talk a little bit more about this. This is one that we're going to go over. Cryptorchidism here in a minute. Undescended testes. So let's go ahead and see what the answer is. Oop. All right, so we are kind of saying a 3-month follow-up for the ultrasound exam. All right, our answer is we're going to refer to Jason to pediatric urology. Okay, so let's take a look here. So these undescended testes, all right, cryptorchidism is when one or both testicles don't make their way down to the scrotum from the abdomen during development. Usually within the first 3 months of life, this is going to resolve and it's going to be no issue. And essentially, the right testicle is usually the one that's most affected, but it can be bilateral as well. And some of the risk factors include things like premature birth or low birth weights, maternal obesity, diabetes, alcohol consumption in pregnancy, smoking in pregnancy, again, things that's going to lead to low birth weight, and a family history. We don't really see a lot of symptoms with this, so a physical exam is going to be important here, making sure we're taking those babies' diapers off and looking and assessing. And we're essentially assessing for the absence of a testy in the scrotum. So if we're unable to palpate the testicles, ultrasound will be our second line for visualization. Usually there's a watch and wait period, and most of the time, without intervention, about 80% of these are going to spontaneously resolve within the first 3 months of life. However, ages 6 to 10 months of age is about the time when we really start paying attention and looking for these to come down. And if they're not coming down, we're going to refer to urology for a possible surgical consult. And we're going to act aggressively because if these testes have not descended, then untreated cryptorchidism is often associated with infertility and a higher incidence of testicular cancer. So if I go back to my question here, okay, in 3 months, Jason's going to be 11 months old. So not necessarily, if y'all wanted to repeat the ultrasound, maybe while you're waiting for the urology appointment or whatever, but 3 months is probably a little bit too long to wait. And so that's why the answer to this one was refer him to pediatric urology. All right, so let's go ahead and take a look at these. I have 3 conditions here for y'all to look over. So hydrocele is where the fluid accumulates around the testicle. Oftentimes, this is present at birth as a result of injury, infection, or inflammation around the scrotum. And the main symptom of this is going to be a painless scrotal swelling. And essentially, when you see painless scrotal swelling, inability to palpate the testes, and taking your pen light and shining it right there and looking on the scrotal sac, and the light shines through, means that there's probably fluid in there versus actually a solid mass, and you have most likely successfully diagnosed a hydrocele. This is essentially a clinical diagnosis, but ultrasound to evaluate for things like inguinal hernias can also be considered, or if you're not sure, you can also get an ultrasound. Sometimes these will resolve on their own, but for prolonged or symptomatic cases, surgery will be required. So just one little thing here to pay attention to. A varicocele is another testicular condition that I want y'all to be aware of. This is sometimes referred to as a bag of worms, and the reason is because a varicocele is all these enlarged or varicose veins. Think about the varicose veins we've seen in people's legs, right? This is just happening in this area here. Essentially, the blood vessels enlarge in the scrotum, and they're just kind of the same thing in a different place. But some of these are going to cause pain, some achy, dull feelings in the testicle, and even a feeling of heaviness. Physical exam, basically, you're going to be able to visualize these large or moderate varicoceles, but if they're really small, you may need an ultrasound to look as well to confirm. These can actually result in infertility, so treatment's going to be important, and urology is going to want to perform surgery to correct this. All right, a spermatocele is just a cyst on the epididymis, or the area that stores sperm. We don't really know why this happens. It's pretty uncommon for patients to even have any symptoms. A lot of times these will just be picked up on incidental physical exams, and the providers will kind of feel a painless lump, or the patient maybe is complaining of a painless lump that's separate from the testicle because it's a cyst, right? And a lump can always be stressful for the patient and provider. So regardless of what we feel, we're going to rule out anything more concerning, and we're going to go ahead and order an ultrasound to get confirmation. So unless this is causing a lot of problems, once we've got a confirmed diagnosis, usually we'll just kind of let these ride as they don't cause a lot of problems. But if they want the cyst removed, then that can be done as well. All right, I'm going to wrap things up here before we get into our case study with just two types of male anatomy specific cancers, prostate and testicular cancer. Prostate cancer is a most common form of the non-skin cancer for males, specifically affecting older adults. And then testicular cancer usually is more rare, but it affects younger people usually. It has a good prognosis if we can catch it in time. And prostate cancer is usually slow growing, whereas testicular cancer usually grows a little faster. And risk factors for prostate cancer include advancing age, family history, early sexual activity, obesity, and African American race are going to be your highest risk factors for that. Early stages of prostate cancer don't give us a lot of symptoms to work with. However, later stages, these patients may complain of things like weight loss. They might complain of things like night sweats, blood in their urine, or lower back and pelvic pain that just won't go away. If we decide to do the digital rectal exam we discussed earlier to evaluate for prostate cancer, the prostate might feel nodular, hard, lumpy, and that's going to prompt a further investigation, and we might send this patient on to get a biopsy. In addition, we'll order that prostate-specific antigen or PSA, and anything over 4 should be gone to urology as well. Also, if any value has increased, 25 to 50% each time, so maybe they were at a 2 and now they're at a 4 or 3.9, that's increased a pretty significant amount. So we will still go ahead and send them on to urology. Also, if they had a history of prostate cancer, and they've had some treatment done, we want the PSA to be lower. So there's a few outliers there. And then also for testicular cancer, lots of different things we can use to diagnose this, like ultrasound. And of course, for any cancer, these patients may end up with chemo, radiation, hormone therapies, and lots of different options for treatment here. And remember, as primary care providers, you are going to be our first line defense for lots of different common forms of cancer, and those screenings need to be in the forefront of our minds. Currently, the U.S. Task Force, we talked about guidelines just the other week, didn't we? And there's a C for prostate. So remember, we talked about how some patients will benefit from this, but not necessarily the general population. Right now, that's under review, and screening for prostate cancer in males aged 55 to 69 gets a C. And the PSA is not recommended in males over the age of 70 for general population. And again, wrapping up today's lesson, just making another couple mentions on testicular cancer is that cryptorchidism, that undescended testicle, that is going to be a risk factor for that. Of course, family history of cancers, infections like HPV or Epstein-Barr. And these often will have a painless lump and a swollen testicle, and that should prompt us to order an ultrasound, and that will help to diagnose that. And again, these patients are going to be probably co-managed with urology and also oncology. So don't feel like you're overwhelmed and have to do everything yourself. All right, so I'm going to go ahead and stop here for just a second. I have a few more practice opportunities for you before we go, so hang tight. But that was a lot of material. So any questions that you guys have, go ahead and put it in the Q&A. You can put it in the chat if that's working. I tried to fix it. If it's not, that's okay. Put it in the Q&A. You can also put it in the box on Slido. So I'll give y'all just a minute to do that. And then we're going to move right into our game. This is a little matching game. So I'm going to go ahead and pull the Slido up here just in a minute. Again, for the matching game, let's pull that up. And it's just going to be an open text box. So if you want to put a question in there, you can do that. If you want to play the game, you can do that too. So basically, this is going to be matching of what is what. So this is all your terminology, all your vocabulary of the things that we kind of talked about today and touched on. This is just a little practice for you. So again, these are going to be out of order and you need to match them to their vocabulary words. So I'll give you just a minute to work on that while I get the case study set up for you. We have just a little, real short little case study at the end here. So don't run off too fast. But if you need to refresh your coffee or whatever, now might be a good time to do it. And I'll go ahead and let y'all look at this and take a look here and see. So you'll put a letter with one of these numbers is kind of how you will play this game. So, you might have varicocele, B with 6, B6, and just go down the line and kind of match them. And again, I'm just kind of playing around on Slido. It's still kind of new, something we just kind of started in 2025. And I'm just coming up with other things for y'all to do in here. So maybe you like it, maybe you don't. You can leave me a comment if you don't like it, and we'll try something else next time. So go ahead, go on the Slido. I see a few of y'all starting to type. I'll put it back up for you, match this, and then I'll give you the answers. And then we'll get into our little case study here and we'll wrap it up. We're almost done. We have just a few minutes together. So I'll open up the Q&A while we are waiting for y'all to do the matching game. And we'll go from there. We will go from there. So Slido's here. Y'all type, y'all fix it up there. I'll look here at y'all have Q&A. I'll take a look at that. Like I said, this is going to be an open text box. So if you have something you're wanting to tell me, you can tell me on the Slido too. All right, so you guys are working on this. Okay. All right. So I'll give you just a minute to put in what you want to put in on Slido, and then we will come right back to it. It's been so rainy and stormy here where I'm at. Usually it's been sunny here lately. So I hope the weather where y'all are at is a little bit nicer today for you guys. All right, let's go ahead. Great job, you guys. All right, wonderful. Okay, so let's go ahead and take a look here. Good job, you guys. Y'all are all putting it in. Great. So let's go ahead and take a look. Here's your answers. Okay, so we have the painful erection lasting over 4 hours. The varicocele is that enlarged blood vessels or bag of worms. Spermatocele is the painless lump, separate from a testicle, most likely a cyst. Ballantitis is that infection of the glands. Peyronie's is going to be that scarring that causes the bend and curvature of the penis. Cryptorchidism is that undescended testes in the babies. Phimosis will be unable to retract the foreskin from the tip of the penis, whereas that paraphimosis is that one that is retracted, causing the painful constriction of the glands, and the hydrocele is the fluid that we can see with the transillumination. So you guys got it. Great job, you guys. That was a little matching game. Some of y'all are still putting in, finishing up that, and that's okay. All right, so again, just a little practice for you. All right, I'm literally going to take 5 minutes and go through this very quickly. This is our little case study. Let's just do it together. This is Mr. Carter. He's 53. He presented to the primary care clinic today for his annual physical exam and states, Over the past 6 months, he's had a decreased ability to achieve and maintain erection. He reports increased strain in his marriage due to decreased libido and ability to perform. And he denies pain or deformities. And he states he is still having morning erections, but not as firm. He does, I put denies. He complains of increased stress at work. Sorry, that's a typo, but denies any drug, alcohol, or tobacco use. His past medical history includes type 2 diabetes and hypertension. And here's his medication. He's on metformin and lisinopril every day, metformin twice a day. And I want to know what your initial thoughts are. So I'm going to go ahead and pull up the slide over here. What are your initial thoughts? Again, no wrong answers for this. What are you thinking that we're going to do, and what questions would you like to ask Mr. Carter? So think about what you are initially thinking for him. What is maybe a differential diagnosis? Just listening to his history. What are you wanting to start to wrap your brain around? So go ahead and put down your initial thoughts. Again, no wrong answers here. Okay. So I'll give you just a minute to write that down. I'll pull up the slide again. You can go back and look at that. He's been stressed at work. He denies any drug, alcohol, or tobacco use. He has diabetes and hypertension, 53 years old. He's had some increased strain in his marriage due to decreased libido. And this has all been going on about the last 6 months. So what do you guys are thinking about Mr. Carter? So, okay, all right, okay. Yep, that's right. I like it. What do we want to check? Stress levels, that's right. It's diabetes. I'm interested to know what his A1C is. I know you are too, right? Stress levels, that's right. Differential diagnosis, absolutely. Erectile dysfunction. What's his testosterone? Absolutely. So you guys are right on the right path. I love it. Okay, so that's just your initial thoughts. Great. So let's go ahead and get a little bit more information on him. So he's in here today. His vital signs are just a little high on his blood pressure, but it's okay. It's stable right now. Everything is looking good here as far as his actual exam goes. He's a little anxious because it is kind of a stressful topic to talk about with you today. His A1C is 7.9%. Fasting glucose is 158. His total testosterone is 281, so that's just a little bit on the lower end of normal, though. TSH was normal. Cholesterol is not to goal. Here's his LDL. He's got type 2 diabetes. LDL is not to goal. BUN, creatinine, so his kidney function's okay. He's not spilling a lot of protein in his urine. His ratio's okay. So what do you want to discuss with him? So I'm going to go ahead and open up the Slido again for y'all. What should you want to discuss with Mr. Carter, and what are your differentials? So I'll pull this back up for you. So again, he's here for a primary care annual visit. He has a complaint, but we have some time to talk with him today. And we want to assess him holistically, right? We are wanting to have health promotion and disease prevention. And so thinking about his labs and his blood pressure and everything, the whole picture together, what are some things that you want to talk about and address with him today? So what do you all think might be contributing factors? What do you think might be helpful for him? Where do you want to start? Is there any other questions y'all might have for him? Is there any other, assessments that you want to do? So let's go ahead and pull up our Slido and put down. So we need additional diabetes meds and lipid lowering agents. Okay. All right. What about his lifestyle? How's he been doing? He's been stressed. Is he taking his metformin, right? Is he taking it twice a day? What's he eating? Is he exercising? We have none of that information, right? So, so let's think about what we want to do with him, what we want to instruct him to do, what our differentials are. Okay, decrease his stress level. That's a great idea. That's going to help him tremendously in all of this management, right? It's going to make his blood pressure a little better, his blood sugar a little better. Healthy diet. We want to talk to him about that, right? How much carbs and sugar is he eating? We want to know that, right? He might be taking his medicine, but he's not following his diabetic or heart healthy diet. So we really want to talk with him about, what's going to be next with his lifestyle, right? So I'll give y'all just a minute to put in what you want to do, and then we'll go after that, okay? All right, looking good, guys. All right. So this is the International Index of Erectile Function questionnaire results. This is just an example on a made-up patient. But basically, this all boils down to, if you went to that website, there's more questions than this, but I really want you to focus on what his problems were right here. And so essentially it's recommending psychosexual counseling. So if you add all these things up together, it's going to say like urology, or it's going to say, maybe more labs or whatever. But this one here, when you add this stuff up together, is going to recommend starting with psychosexual counseling. So what do you recommend today to wrap up the visit? Okay. So what are you going to recommend today? So go ahead and let's talk to him. We're going to, of course, recommend psychotherapy, maybe get his partner on board. We're going to, we've already kind of talked about the medicines. What do y'all want to give? What do y'all want to do? And this could go, a variety of ways, right? So y'all are kind of driving this ship. So what do y'all want to do for this patient today? There's a lot of correct, good answers. So, yeah, okay. I didn't see any cholesterol meds for him, right? So, definitely wanting to be talking to him about statins, right? Doesn't have his ACSVD risk calculation score, but I bet it's high. He's definitely not to goal. Goal's going to be 70 or less, right? He needs more blood sugar control, absolutely. So whether that's lifestyle modifications and or adding one, maybe a GLP-1, something like that to give him a little bit more blood sugar control, maybe a little bit more metformin if his kidneys are stable, which it said they were. Okay. Yep. Yep. So we are probably going to do a digital rectal exam on him today. Okay. This is his initial visit for complaint of that. Yes, he's here for a physical, but he also complained of that. So, prostate exam during a physical, not unheard of, right? So we can do that. Okay, yep. So follow up on A1C in 3 months. Yeah, absolutely. So you guys have lots of great ideas. So let's go ahead and just wrap up this case. Mr. Carter has started in psychotherapy with his wife and reports improved symptoms after 3 months. He reports compliance with lifestyle and medication changes. Whatever you guys did, y'all did lots of options on there and they were all good. His A1C is now down to 6.7 and his LDL is 83. So he's getting much more closer to his goal. He's done some lifestyle changes and he's reported that he has greatly improved. So good job, guys. Again, remember that erectile dysfunction is multifactorial. There's not going to be one size fits all treatment approach. Often a combination of metabolic, vascular, hormonal, and psychogenic causes. And again, lots of different ways to kind of go about this. And remember, we always have urology. If things weren't getting better for him, we can always send him there. So great job, you guys. I will pull this slide up one more time. If there's anything that we can help you do, let us know. I'm going to do a little knowledge check on you here. How are you feeling about your knowledge in men's health topics? Let's go ahead and fill that Slido out. So somebody's feeling nervous about it. That's okay. That's okay. So how are y'all feeling on your knowledge? I'll leave that up for y'all. Y'all can fill that out. And again, if you're feeling nervous about it, that's okay. You can go back through, you can look at this and listen at this lecture again. You can, look over your books. You can book a mentor session. You can look at it through on demand. There's lots of ways that you can get more information. So that's okay. So, all right. Okay. Getting a little better. All right. So there's some confident ones out there too. Okay, all right, that looks better. Okay, so let's go ahead and ask the last question of the day, and that is going to be, what other topics would you like to see us present coming up? Right? We're always open for new topics, always open to work on some new stuff for you. Let us know. We're happy to um, hear what you have to say. All right, GYN infections, lots of different topics that we can look at. Professional practice, I did that last week. Go back and look at that. Hematology, the anemias, breast conditions. We talked a little bit about breast stuff last week, but we can do more. So yeah, just let us know. We're happy to talk you through what you're interested in. So um, you guys, we can definitely talk more about that. Okay, so I'll go ahead and write these down. All right. Yep. Okay, hypertension, absolutely. Okay, listen, I am not going to keep y'all. I'm going to give you the rest of your Monday back. I'm here. If you have specific questions, you can put it here. This is an open text box. I've got the slide up for you. If you want to, look at this SurePass Pro or Question Bank or email us, whatever. Like, we're here. It's fine. Let us know how we can help you reach out. So I'll put that up for you. Can I switch my tests from ANCC to AANP? Yeah, I think so, but I don't know if you'll have to pay the fee or not for that. That might be an email that you send us that you could explain specifics or whatever. IBIC 3 lecture. Okay, y'all have been requesting that. I'll have to put that on the calendar for May. That's hypertension, diabetes, and hyperlipidemia. We will talk about that coming up soon. So I will put that on the calendar for you. You're welcome. You're welcome, whoever wrote that. Okay. Yep. All right. Yes. Yes, you're welcome. Okay. All right. So hopefully y'all are feeling a little better. Let us know what we can do for you. And I'm going to plan to see y'all next week if there's no other questions, and have a good rest of your Monday.